In fact, in the morning in the session, we used to talk about the LA, importance of the LA, where within the LA maximum volume we stressed upon till now, but it is beyond that I am talking to you. See, left atrial enlargement and dysfunction are increasingly recognized as a biomarker for adverse cardiovascular event. Only maximum LA size, that we called LA max, was considered a clinical relevant prognostic marker. But now, presently, minimal LA volume, what Dr. Nitin was speaking in the morning, is, and the phasic function parameters have been reported to be more powerful predictors of outcome in various cardiac conditions. Moreover, non-invasive estimation of the LA pressure has gained importance to fully characterize the hemodynamic profile of the patients. Actually, to determine the total LA parameters function, these are the things. First is the LA size, LA function, Doppler parameters of the LA function, strain parameters of the LA function, LA pressure, prognostic value of LA metrics, and the LA function in clinical practice. These are the actually. For the lack of time, within 10 minutes, I cannot cover all this. What I'll emphasize is that left atrial volume is a surrogate marker of the severity and chronicity of the left ventricular diastolic dysfunction, where left atrial volume is very, very important. There are three important volumes. See, important is that LA diameter underestimate LA size, and LA enlargement is asymmetrical. Hence, using LA diameter identified only 50% of patients with the enlarged RA, whereas 76% is determined by the LA volume. While determining the volume, there is very important, you have to trace that it's shown in the morning, tracing the endocardial border, this LA appendage. It has to be excluded, the LA appendage, pulmonary veins, and the funnel of the mitral valve. That in the morning we have described. So there are three volumes. One is the LV max volume, is measured just before the mitral valve opening. One is the pre-LA volume, that is the LV pre-A, that is the onset of the P wave on the ECG, and as the LV min, that is the minimal volume at the end diastole before the mitral valve closure. And you can determine all the phasic LA function and the active and the passive emptying volume and fraction and the conduit volume, and you can calculate everything by these three. This is I am not going to discuss, I already discussed in the morning how to acquire this, but also these are the three volumes. Also what is the importance is that you can do it either in the 2D or in the 3D. The same thing. Of course, the 3D will give the good parameters. These all I have discussed in the morning, that LA axis and the LV axis is not the same. So you have to be very careful to find out the long axis of the LV. And you can, 3D you can do the volumetric analysis in by one go. You can, by putting the 3D volume, you can get the minimum volume, maximum volume, pre-A volume, systolic strain, conduit strain, and contractile strain. Everything you can go in the one go. That you can do. By, you can see everything you can go and go in the one go. You see all the volumes and all the, you can see all the volumes and all the strains. These are the three strains and the three volumes. I'll give some example. So these are the three total volume. Ejection volume is the passive ejection volume, active ejection volume, and the Vmax, V pre-A, volume, minimal volume. These you will get all with the 3D in one go. Why it is a 34 millimeter? That's in the morning I was telling. The revised value of 34, more than 34 millimeter mercury millimeter per square meter to define LA enlargement is perhaps more clinically relevant because in LV max, more than 32 millimeter per square meter was associated with the adverse outcome in ischemic stroke, diabetes, and heart failure. That's why the 34 is more important. So these are the, actually we summarize the, what I told you was this take-home message. Now, I told you the function, one is the reservoir function, one is the conduit function, and is the contractile function. And of course, the fourth function is coming, is the suction, so that refills itself by the Arlis stone. And these function you can depict from the 2D or in the 3D view. For example, I'm giving an example, see. Otherwise, it will be futile attempt. So this is a patient, is a normal LA size, normal, everything looks normal, both 4 chamber and the 2 chambers view. So if I plot this patient, the apical 4 chamber view, LA max, there is the LA min, and this is the LA pre-A. These 3 I took it. And this is the 2 chamber LA max, LA 2 min, and LA pre-A. And what do we get it? The LA maximum volume index is 18, 7, and 18. All are within normal limit. You can get 3 volumes in a go. All are within normal limit. And now find out all the function. You can find the volumetric function by these formula. And you can see every parameter, these are the normal range, and you can see every parameter is a normal. Nothing is in red. So you can conclude this is a normal volume, LA volume, and the normal LA function. Now come to the second case. This case I did the same way, the maximum pre-A and the minimum volume. For lack of time, I'll go to the directly to the what I have measured. The method is same. What do you get it? LA maximum volume is increased, mean volume is a little increase, and pre-A volume is also little increase. Now we plot it, the same thing to find out the functions. You see, there is a definite reduction in the LA expansion index. There is a reduction in the emptying fraction. There is a reduction in the LA active emptying volume, and of course, there is a total emptying fraction is reduced. So here we can kill, but certain other functions are still within normal limits. So we can conclude there's something that enlarge LA volume, and there is some mild dysfunction of the LA, only from the volumetric studies. And another case, in the third case, if same way, this is the plot. You see, there's the largest volume in the maximum volume, and the minimal volume in the pre-volume. And now we put it in the jot it out. You find almost everything are abnormal. You see LA expanded index is abnormal. There is a emptying fraction is abnormal. Conduit volume is abnormal. Even the active emptying fraction is abnormal. And there is grossly abnormal the total emptying fraction. That means you can conclude this is an enlarged LA volume and the severe dysfunction of the LA, only from the volumetric studies. So among these, remember that left atrial total emptying and the passive emptying fraction measured by 3D are larger than the corresponding measurement by 2D. Conversely, LA expansion index and the LA active ejection emptying fraction were similar measured by either 3D or 2D. So these are the, what I told you is the same take-home message. Now come to the strain. Strains are less load dependent. Of course, and the reserve component of the LA phasic functions. We can do, of course, with the TDI, but TDI is definitely low reproducibility and that depends on the angle of insonation, where 2D speckle trunking is very good. So if I do it, the longitudinal strain of the LA, see, the only important is the longitudinal strain, and if you do it, then either in the reservoir strain, there is a I told you conduit strain, and in the contractile strain. So if this is the peak reservoir strain, there is a peak systolic strain, then is the conduit strain, and again this is the contractile strain. See, this is the reservoir strain, conduit strain, and this is the contractile strain. So this way. So putting this same patient, now putting this first patient, you remember, then put it the LA strain. You see the strain is absolutely normal, reservoir in 35. And conduit strain is 18, and the contractile strain is 12. So everything is normal. Now coming to the second case, you see the contractile reservoir strain is decreased, nearly almost 18%, and 10% and 6. And in the last case, you can see the reservoir strain is only 9 and then 6. And of course, the last case, this is the LV strain I have shown you. So the take-home message is that. And among these, the peak systolic strain, more than 19%, proved to be more accurate than left ventricular volume. Mind it. Now, peak systolic strain is considered more robust than left ventricular volume index, more than 34 milliliter. And the pulse and the conduced strain was significantly impaired even in HEPEP compared with the non-cardiac dyspnea. Of all echocardiographic indices, pulse best discriminated HEPEP from non-cardiac dysplasia. So my conclusion, this is the last slide, measurement of the LAF thought to be limited to the evaluation of the LAF maximum volume. However, there are emerging data to support the role of LV minimum and phasic LA volumes as well as the LA phasic function utilizing 2D strain analysis. The particular areas of relevance of LA metrics in the clinical area of patient include evaluation of the LV diastolic dysfunction, HEPEP, and atrial fibrillation, all of which are common and growing problems. While more comprehensive normative data and the robust evidence in prognostic utility of the newer technique, including 3DT and strain analysis, are warranted, it is likely that evaluation of not only LA volume, but LA function parameter will be included in the future guidelines on the evaluation. Thank you.
Thank you, Aniruddha, for the beautiful disposition of the new look into the left atrial volume, different volume parameters, and different LA function. You have thrown some new light and take-home message for the audience. Thank you very much. So with these remarks, we end this session, which has been a very interesting session, but for the time, absence of time for discussion. Thank you.